Good morning, good afternoon, or good evening, depending on where you are joining us from. Welcome to the fifth edition of the International Seminar Reference and Construction of the Political, Socioeconomic, and Health Dimension of Pandemics and Endemics, Significant Before, During, and After. The aim of this seminar is to create a space for dialogue of collective reflection where we can examine two ongoing needs, challenges, and unresolved issues surrounding contemporary pandemics and endemics from a range of disciplinary and contextual perspective. My name is Dr. Maria Guadalupe Ramirez Rojas, and I will be your host for today's session. Today, programs include 3 presentations, each with a maximum duration of 20 minutes. Following the presentation, we'll be invite guest discussants to offer a critical commentary on the papers and to open the floor for discussion among the presenter as well as for questions and comments from the audience. After the academic session, we'll be moved to the second part of the program, which will consist of a cultural activity included the recitation of poetry as a closing segment of today's event. Without further ado, it is my pleasure to introduce our first speakers, Dr. Daniela Calvo from Kyoto University. Daniela Calvo is a host researcher at the Graduate School of Human and Environmental Study of Kyoto University, where she recently concluded a postdoctoral fellowship of the Japan Society for the Promotion of Science. She holds a PhD in social science from the State University of Rio de Janeiro and a PhD in mathematics from the University of Pisa. Her research revolves around Afro-Brazilian religions in Brazil, Italy, and Japan, with focus on holy rituals more than human relationship, food, and gender relations, sacred space, memory, the COVID-19 syndemic, migration, and transnational processes. The title of her presentation is The Color of COVID-19, Racism and COVID-19 Syndemic in Brazil. Dr. Daniela, welcome. The floor is yours.
Thank you very much, Guadalupe, for organizing this very interesting seminar and for the invitation to present my research. I will present today a development of my study on how COVID-19 syndemic was interpreted and faced by the practitioners of Afro-Brazilian religions, concerning the relation between COVID-19 and racism in Brazil. I concentrate on blacks and pardos, that are brown mixed according to Brazilian official classification, but I observe that other groups like indigenous peoples, gypsy communities, and people living in remote areas also suffered severe consequences of COVID-19 and share some of the problems that I'm going to present. COVID-19 quickly became a health, economic, political, social, ideological, moral, and information emergency. The probability of being infected and dying, as well as risk perception and access to treatment, varied according to manufacturers. The concept of syndemic, proposed in 1996 by Meryl Singer, described the interaction of epidemics with other diseases and the psychological and structural factors that enhance their effects and the vulnerability of individuals and groups. This concept allows to consider how viruses or bacteria, including SARS-CoV-2, operate in human societies, interacting with a number of factors such as economic, ethno-racial, political, and gender inequalities, age, genetic, other diseases, living conditions, geographic spaces, urban architecture, public investment, drugs, vaccines, scientific paradigms, religions, denialism, fake news, etc. In Brazil, the COVID-19 pandemic erupted in a context marked by severe socioeconomic, ethno-racial, geographic, and gender inequalities, and by structural problems, such as the precariousness of the public health system and the lack of social safety nets. Let's contextualize my research by speaking a little bit about racism in Brazil, and to contextualize, over a population of around 230 million, 45.3% declare themselves pardos, brown or mixed, 43.5% white, and 10.2% black, with a great variability between the states, especially between the North and the South. The census is based on such definition, and this definition of race is very complex and mostly based on phenotype. And people may change their definition along their life. In the last years, it happens also because of affirmative actions for Black people and campaigns of conscientization, and more people declare themselves Black or Pardos, or passed from white to Pardo or from Pardo to Black. Structural racism marks the history of Brazil, where intersectional and multidimensional inequalities persist. Racial, socioeconomic, geographical, educational, and gender factors and health factors intersect. Data from the IBGE, Brazilian Institute of Geography and Statistics, show that Blacks and Pardos have an average rent lower than that of white people, a higher percentage of people living below the poverty line, more food insecurity, a high number of homeless, worse living conditions and less access to services, including health services, a higher presence in prisons, lower instruction, and a higher rate of illiteracy and returning illiteracy. Moreover, while in Brazil private health plans are widespread, about 67% of Blacks and Pardos can count only on the public health system, and a young Black man has twice the probability of being murdered than a young white man. The Federal Constitution of 1988 makes health a universal right and a duty for the state. But this principle of universality hampered the recognition of the different incidences of morbidity and mortality among the population and the presence of diseases that affect specific groups, such as Black and Pardos. This recognition was obtained through the joint struggle of the Black movement, communities and associations of Afro-Brazilian religions, and various social sectors and international organizations. Brazil was one of the countries mostly severely affected by COVID-19 and counts 39,318,2027 confirmed cases and 716,626 deaths, with a big underestimate, especially in remote and marginalized areas. Responses to the pandemic, especially with regard to the treatment capacity of patients in need of hospitalization, massive tests and monitoring, as well as the ability to provide economic support to workers and small businesses, were compromised by structural problems and the overlap of different positions among government agencies. Decades of neoliberal guidelines activated privatization and marketization processes and a policy of disinvestments in public health. Additionally, President Jair Bolsonaro compromised the continuation of the project Mais Médicos, More Physicians, launched by President Dilma Rousseff in 2013 in order to extend medical care to remote and marginalized areas. When the World Health Organization declared the risk of COVID-19 pandemic and contemporarily the first cases in Brazil were registered, Bolsonaro adopted a denialist position, contributed to disinformation, stood against social isolation and general vaccination, clashed with two health ministers who were replaced, and widened conflict with governors of states and municipalities in relation to the policies he adopted. From the beginning, the consequences of the pandemic have been distributed unequally among the population in terms of access to resources that allowed people to isolate and take care of themselves and their families, and exposure to the risk of hospitalization and death. Furthermore, the pandemic aggravated situations of comorbidity, vulnerability, marginalization, unemployment, poverty, malnutrition, violence, criminality, housing conditions, alcohol and drug addiction, and psychological disorders. SARS-CoV-2 began to spread among people whose economic condition permitted travel to Europe, and the first confirmed case happened on February 26, 2020, in Sao Paulo, in a person who arrived from a trip from Italy. Nevertheless, the first registered death for COVID-19 was that of a domestic worker in a public hospital in Sao Paulo on March 12. She suffered from diabetes and hypertension, which may have contributed to the worsening of her clinical conditions. Another death that was initially considered the first from COVID-19 is that of a Black domestic worker living in a humble neighborhood of Miguel Pereira. She was probably infected by her employer, a woman living in a richer neighborhood of Rio de Janeiro, who, back from a vacation to Italy, did not inform her of the risk of contagion, nor did she adopt any preventive measures. These two deaths are exemplary of the interaction of racism and socioeconomic inequalities with COVID-19. In fact, in contrast with the privileged portion of the population that could adopt measures of prevention from contagion, and in case of need could afford a bed in a private clinic, many low-class workers, including domestic workers, caregivers, janitors, informal sellers, bus drivers, deliverers, that count many Blacks and Pardos, saw their rent compromised or were highly exposed to the risk of contagion, since, in order to survive, they were compelled to continue to work in a situation of insecurity and to travel in crowded buses and subways. Moreover, according to Offlink, when they get home, the spread of the most precarious housing, especially in the favelas, has an enormous propagating potential. In some cases, this situation was aggravated by the lack of basic sanitation and water. When sick, they competed for beds in the crowded hospitals of the public health system, already in disarray and not uniformly distributed around the country. As a consequence, compared with white people, Blacks and Pardos of all ages who were hospitalized for COVID-19 presented a risk of death significantly higher, and skin color was the second risk factor of death for COVID-19 after age. We need to consider that a wide range of non-communicable diseases, including hypertension, obesity, diabetes, cardiovascular and chronic respiratory diseases, and sickle cell anemia, are widespread among Blacks and Pardos, with the consequence of aggravating the risk of severe repercussions in case of contagion by SARS-CoV-2. Furthermore, There was an unequal distribution of vaccines. At the beginning of the vaccination campaign, data revealed that white Brazilians had received twice as many vaccines as blacks and pardos. This disparity was influenced by priority given to the elders in this phase and the fact that white people have a higher life expectancy than black and pardos. Nevertheless, the disparity persisted after the first phase of the vaccination, when people of all ages received the vaccines. According to Beatrice Zolin, the factors that may have contributed to this disparity are the following: the higher percentage of elder people among the white population, the difficulty of access to vaccine distribution for people living in the peripheries, favelas, and interior areas, the time of vaccine distribution that often did not accommodate the needs of the poor population, the unequal distribution of vaccine among the states, the dismantlement of the public health service, the spread of denialism and the critique of vaccination by President Bolsonaro and some new Pentecostal churches. These data are not precise because the delay in the collection and persisting insufficiency of data on the ethno-racial distribution of deaths from COVID-19 and vaccination rates, the inability to analyze the complexity of the syndemic and the intersectionality of class, race, gender, geography, and disease distribution, structural racism, state necropolitics, and the blame for lack of discipline in COVID-19 prevention attributed to Black and Pardos by many state governments. They all contributed to the absence of special policies directed to Black people. During COVID-19 pandemic, many low-class workers, that include a high percentage of Black and Pardos, needed to move in crowded buses and subways and maintained those services that allowed the safety of a privileged part of the population. They were also avoided and accused of improper behavior and propagating SARS-CoV-2, thus sharpening social, ideological, and political tensions within society. Among the 8 million persons that lost their job between the first and the second trimester of 2020, 6.3 million were Black, corresponding to 71% of the total. Low income and unemployment also favored the increase in the number of homeless. Specific groups such as the prison population and the homeless that count a high percentage of Blacks and Pardos were very highly exposed to the risk of contagion and death from COVID-19 and had their living conditions drastically worsened by the pandemic and the measures adapted to contain the spread of the virus. The increase in the cost of common foods, such as rice and beans, in 2020 worsened the condition of poor families in an already compromised economic situation, often leading to malnutrition and worsening of their health conditions. Online schooling brought new problems to poor families, especially those living in crowded and noisy favelas and urban outskirts, where children could not find a proper space to study, had not a computer, and internet connection and sometimes even electricity are lacking. Children lost their school meal, which had an even greater impact when food was scarce in their homes, had difficulties in following homeschooling, and were more exposed to the risk of early school leaving and engaging in criminality. Mothers compelled to bring their children with them to work, causing a series of troubles and risks. For instance, Miguel Octavio Santana da Silva, 5 years old, died in June 2020 after falling from the 9th floor while his mother, a domestic worker, left him in the custody of her employer while she was walking the dog. Another consequence of homeschooling was the higher exposure of children to the risk of dying, being harmed, and suffering psychological traumas from police operations in the favelas that continued during the pandemic, with traffickers, officers, and gunshots entering people's homes. The case of João Pedro Matos Pinto, 14 years old, who died in his house in São Gonçalo in the metropolitan region of Rio de Janeiro on May 18, 2020, during a police operation against drug traffic, caused a great commotion and protest concerning the violence and children's vulnerability in police operations in favela. And both Miguel and João Pedro were Black. To conclude, I observe that the dread of becoming ill or losing relatives and friends, economic insecurity, family conflicts, and loneliness exacerbated psychological disorders such as insomnia, anxiety, depression, as well as drug and alcohol abuse. All these problems and forced cohabitation of family members also led to an increase in domestic violence and feminicide that especially affected Black and peripheral women, and these issues was not efficaciously addressed by the government. I leave you some references and I stop here. Thank you for your attention.
Thank you very much, Dr. Daniela Calvo, for your presentation. We would like to remind everyone the discussion and comments we take after the three presentation. We'll now move on the second presentation of today's session, delivered by PhD candidate Javier Garcia Martinez from Monash University and the University of Warwick. Javier Garcia Martinez is a young PhD student at the University of Warwick and Monash University with training in sociology and science and technology studies. Her research explores what it means to live with antidepressant, tracing how selective serotonin reuptake inhibitors shape everyday practice, care, and affect through a digital ethnographic approach. Drawing on medical science and technology studies, care studies, affect studies, and math studies, her work examines that intimate and often ambivalent entanglement between humans and pharmaceutical technologies. The title of the next presentation is Ontological Odysseys in the Silent Pandemic, Becoming with Antidepressant. Dr. Javier, welcome. The floor is yours.
Thank you. Can you see my screen? Yeah? Okay.
Yeah.
Thank you. Thank you very much for the presentation, and thank you very much for organizing this session here today. Definitely an amazing series of seminars you have organized here, so I'm very, very glad to be here with all of you today. So yeah, as colleague Guadalupe said, I'm a PhD candidate from the University of Warwick and Monash University. And so I'm here to talk today a bit about part of my PhD, which is now coming to an end, hopefully soon, next year. I'm going to talk about those odysseys of the silent pandemic, that is for those who live with antidepressants, who live with taking pharmaceutical, and in this case, specifically focusing on SSRI antidepressants, which are the most prescribed kind of antidepressants all over the world. We are talking about at least 60% of the antidepressants prescribed are usually this kind. So I focus on these ones, and specifically the relationships that people establish with them, right, in their everyday lives specifically. How does it changes them? How does it change how they live the everyday just by taking them? As a reminder, these are not only prescribed for depression, these are also prescribed for all sorts of mental health diagnosis, meaning from PTSD to schizophrenia to anxiety. So these are extremely common, and these are a first line of medical intervention to what we could call a mental health crisis that we are going now, we are going through right now worldwide. Sort of as I was saying, kind of a pandemic, a silent pandemic that is going on as sorts. Silence in the sense that it is very difficult to find spaces where people discuss the mental health diagnosis or what pharmaceuticals they are taking openly. So that is why I did my methodology in online spaces where people, it is in a sense almost an exception to this rule, where people feel free to some extent to speak about their mental health, to some extent about their prescriptions. So I focused on mutual help, online groups in the app Discord. These groups are not mediated by any sort of mental health professional, no psychiatrists, no psychologists. It is just people who want to find others who are also going through similar experiences. I focused on Discord because of its privacy policies. At least they are there to some extent. These kind of groups are very common across all platforms on the internet, across social media. They're extremely common. So I did digital ethnography. I went into these groups, lived with them, did interviews, a series of interviews with those who volunteered to do so, just to give some degree of context. These groups can be very big, right? Some of the ones that I have been part of have from 800 members to thousands of members. So we're talking about very large groups of people who join, and some of those are, there are more active ones, less active. There are people who log in every day and leave a message. There are others who just stay for a while, or they just look and lurk around and then leave, right? It depends, right? This is kind of a bit of the interface of Discord, just so you have an image in case you're not familiar with it. It is very much a chat-based interface, chat-based app. I did my interviews through text, video, or audio, right? Depending on who, depending on the person I was interviewing and what they preferred. I'm going to go through some of the experiences that people share with me, mostly on interviews, and I'm going to present them in a way that feels as a sort of multivocal, where I bring different voices into each of the themes that I raise here, just so you have at least a grasp about the complexity of what's going on here and how these people go through these journeys with antidepressants. So there are people who just take antidepressants for 2 weeks. There was an instance of someone who took antidepressants for just 2 weeks and then left it. Right? People, in this case, this man from Mexico was telling me how he only took it for 2 weeks and it felt so bad that he had to stop immediately after that. Some others have been taking them for years and years, right? In this other case, this woman from US has been taking them for more than 30 years. So we have very different range of duration of how long people have been taking them. And there's a lot of breadth as well into the amount of pills and pharmaceuticals they have taken. There are instances of people who have multiple diagnoses, mental health diagnoses, so they might be taking other pills at the same time that are not antidepressants. You have people who are diagnosed with ADHD, for example, or with anxiety, or who have trouble sleeping. And so there are instances like the first one here, the first quote, where we have someone who, I talked to someone who is taking 6 at the same time at that point when I was interviewing them. There are others who have been taking antidepressants, but they have been changing over the years because they at some point stopped working and they wanted to try a new one. And so this other woman from US was telling me she has tried around about those 30 years of experience, around 12 different ones. So they become their own experts on psychoactive drugs based on their embodied experiences, the experiences that they felt in their body throughout the years with all those different pharmaceuticals. And it's important to be aware of how these change, living with antidepressants, they change the experience of how it is living in their own bodies, but also outside of the body itself, right? In the body, right? From stuff like gaining weight. Here, there are some instances of people talking about gaining weight, to sexual desire. There are people who point stuff that happens outside of the body, meaning relationships with their family might change, they might improve, and they may become worse. Same with friends, same with work, with the studies. So there are these very complex changes that happen that at times contradictory depending on who you ask. That is what makes antidepressants a very challenging object of study for me, but also for medical sciences in general, right? So I would say I would classify them very much. It really gets into this category of pharmacon, and pharmacon as a concept in medical anthropology means substance that can be both a poison or a medicine, right? It is relational in the sense that, it can be harmful or technology for harm or technology for care, depending on related to whom, right? It is this very complex tapestry that makes it difficult just to put them into one or the other category when you have people that are saying very contradictory things one from another. I'm going to taking into consideration these complex journeys on how it feels to be, have that embodiment of the antidepressant, going to go through some moments in that journey that feel very significant, like the act of stopping pharmaceuticals and how some people do it with expert, with a medical guidance, and others do it without it, because usually when they do it without it is because they feel they are not working anymore, or they want to give it a try without them, right? Some instances, yeah, they are stopping because in the second case, talking about someone, this woman from Canada was saying how she has stopped them because she felt these effects were similar to chemical lobotomy, right? And there was another instance where, and he's not the only one, there are people who stop the antidepressants, then feel very bad, and then take them again. And so sometimes in these continuous cycles that happen more than once. There are a lot of speculation about their own futures from these people, from those who accept they will take antidepressants their whole lives, who accept it sometimes with resignation, other times they don't mind, for them might be okay. Well, there are others who are still searching for the right antidepressant for them, for the right pharmaceutical, right? There are a lot of instances of people who know they might be working now, but they have had experiences where they develop, they became tolerant to them. It didn't make them feel as good over time, after months of taking them. So they know they might have to change at some point as well. So they already thinking about that happening. And there is something very interesting about this whole journey that implies this embodiment, that implies really thinking through about what it means to be living with antidepressants. And there's also a search for oneself in this journey. And this is very interesting to me because people are challenging what it means to be themselves. People are challenging their own being in an almost existential kind of way, where people are questioning, what does it mean to be myself? Does it mean to be with antidepressants? Does it mean without them? There are people who feel more themselves with antidepressants than without them, right? There are people who want this, what they call normalcy. They want to feel normal. So they might use antidepressants to feel normal, or they might quit antidepressants to feel normal, right? At times, the same practice has opposite consequences. So it's almost this questioning of oneself in an almost post-human kind of approach, where we are thinking, am I, my being, is it me, person with antidepressants or without them? And the response is never straightforward, and it requires a lot of self-reflection that these people, before I ask them, usually have already been going through to some extent, right? There are also a lot of reflection about this journey that they make, and they chose to share with me these trajectories, these journeys that at times can be very, very complex. Very often they are painful journeys. It's very rare to see someone who has been going through a soft journey of with antidepressants or with the pharmaceutical journeys. And some people are still trying to find stable place, right? And I chose the metaphor of Odyssey for this presentation for that same reason, right? Odyssey in the sense of the metaphor of trying to find a home, of that journey trying to find a home. And in a sense, this is almost an ontological, right? In the sense of they try to find a state of being where they feel comfortable with, be it with antidepressants or without them. And it's a very, very complex journey. Usually, yeah, as I was saying, very painful, mostly because of the very difficult experiences. We are talking about how in the clinic, their experience is usually just trying different pharmaceuticals, different antidepressants until one of them works. And for some people, they found one that works for them, but there are others who are still searching. There are, of course, very obviously barriers of entry. There are many barriers at many points that have to do with access to medical appointments, access to pharmaceuticals, access to, in this instance here of this woman from Spain, to have access to a psychiatrist is even very challenging in her case. And this is a journey of trying to find care, in a sense, right? Trying to find that place where they find care. And it might be in some instances there were people I talked to where they found, their home in stopping antidepressants altogether. For them, that might be the end of the journey with antidepressants. And they might be in some other journeys, but they found antidepressants were not for them. So these are very complex journeys that at times it's very difficult to know at what point they end. There are some people that feel like they know for sure where they are and where they need to be. I would like to end with just a bit of a kind of discussion section on how my work tries to get into discussion with these other very important pieces of work that also influence and inspire my own research, right? Thinking about care in a sense of not only human-centered, but also these other pieces that go beyond the human or more than human, right? In this case, in discussion with Maria Puig de la Casa, we're talking about care, not only as something that pertains to humans, but something more of an expanded definition of talking about care. Here, talking about care with antidepressants means thinking about the relationality between antidepressant and the human in very, very complex instances where that relationality it's more important even that, you know, the antidepressants as an essence, it is not something given or fixed, but rather in constant negotiation, reconfiguration. And we are talking about patient journeys, and of course, you know, Anne-Marie Moore with logic of care, and thinking about, right, the next step is thinking about how can medical professionals think about care in a sense where it's not just a, you know, antidepressants are not just one place stop, one fix journey, where they try to understand the complexities of antidepressants beyond just a substance that is a medicine, but rather something that is much more complex. Thinking about not just choice, patient choice, but about patient care and logic of care. Sometimes it might even entail disagreeing with patients, but just there needs to be a more complex, a more nuanced discussion that actually in what's happening in the clinic, it is far from being this nuance when antidepressants are just overprescribed all over the world as the pretty much almost the only first line and at times only solution for mental health concerns. So overall, just wanted to wrap up by saying about, you know, these very difficult odysseys that people are going through. It's just a way for us to think about antidepressants, but also beyond that, about those other technologies and medical interventions that go through these very, very difficult and complex journeys that the patients go through. Hopefully we can keep thinking about how to improve those for everyone, for patients, practitioners, hopefully in more caring outcomes and environments. Thank you. Thank you very much.
Thank you.
Thank you very much, Dr. Javier, for your presentation. We will now move on to our third and final presentation of today's session, delivered by Dr. Lubena Sira from Guru Gobind Singh Indraprastha University, India. Dr. Lubena experienced a health-related situation, but she kindly shared her presentation note with us. Anita Nudelman, who is serving as the discussant, will briefly present them and just a quick reading, after which we will move on to discussion and reflection based on the presentation by Daniela and Javier. The title of the presentation of Dr. Lubena is Reconfiguring the Political, Socioeconomic, and Health Landscape of COVID-19 in Urban India, before, during, and after the pandemic. And well, it's my pleasure to introduce Dr. Anita Nudelman. Anita Nudelman is an applied medical anthropologist who teaches qualitative research methods and medical anthropology in the Rekanati School for Community Health Profession at Ben-Gurion University of the Negev in Israel. For many years, she directed a Ministry of Education program of sexual health and acquired immunodeficiency syndrome prevention for adolescents from diverse sociocultural backgrounds in residential school. Her work integrates research, culturally sensitive program development, mentoring, training, management, and evaluation, with a strong focus on empowerment and life skill. She has also worked as a consultant in several African countries on projects related to culture and health, patient-provider communication, and adolescent reproductive and sexual health. And Anita Nudelman has published extensively in academic journal and edit volume. She is co-chair of the International Union of the Anthropological and Ethnological Sciences Commission of the Anthropology of Pandemics and co-organizer of the International Seminar. Well, Dr. Anita, welcome. The floor is yours. Thank you.
Okay, thank you. That's too long. Next time we cut it. Basically, one thing that is not there, what you said, basically, I've done a lot of work in Africa, mostly on HIV and maternal health. But I'm actually gonna take, this is Lovina's paper, and we're gonna show it to you because I summed it up in the discussion. I mean, I couldn't make it, I had to prepare something for our discussion, so I read what everyone here had written, different things, and I looked on this. So basically, she does the same as Daniela at the beginning, explaining the different socioeconomical and health and in the pre-pandemic India, that there were also inequalities, like 776 million slum dwellers, like with a big, of course, India has the biggest population, but anyhow, and 93% of the workforce was informal and without security, and also underfunded public health, like you and other things that we'll discuss later. The other thing that she puts here, important thing, is that informal workers were the first ones to lose their jobs at the beginning of the COVID. The first lockdown, and later on as well. And of course, the medical service wasn't working, and in the end, we'll speak about later, in the post-pandemic, they didn't actually get over the crisis. Now, because she focuses on informal workers, this is really important because they were like the biggest victims. She's not taking it to race like Daniela, to other things. She said these people, like, their livelihood broke, and they had many barriers. Some to their pre-existing precarity before COVID. So food insecurity, weak social protection, and of course, most of them didn't have they had to go to public hospitals that often didn't work. So lockdowns froze the activities of these people: street vendors, domestic workers, construction. People were let go hundreds of millions, and many didn't have contracts nor saving. So this was really a very big problem. And here she focused on this. Informal workers also face areas in rent, utilities, debt. They had more debts, distress, asset poverty more than doubled during lockdown, and stayed 50 or 80% higher than pre-pandemic, which is really, really important. And again, all these women, informal workers, domestic workers, and all these people had really hard conditions. Now, most of these didn't have written contracts. They were working informally, paid leave, social insurance, so they receive almost no compensation or no compensation, okay? And many people finish their contract with, like, you're out of the job, that's it, without notice. Food insecurity, of course, was very high. And here's some data. Again, it's mostly for the informal workers. And the relief scheme for immigrants and cultural workers was almost inexistent. Now, they also had a lot of these. Again, we're on the informal workers, okay? This was a focus. I heard in another place speak about violence against women, but here she spoke about this. She was going to speak. So people, they didn't have their incomes, and the free care was unaffordable because it wasn't really free. And transport, medicines, diagnostic expenses, they didn't know how to get. So there's here some sort of a data that 20%, 90% of the employee respondents could access the care compared to only 68 of unemployed, and it went higher and higher within public facilities. So we have here the whole thing: fear of infection, stigma, overcrowded hospitals, also deterred care seeking. People were scared of going there, and then they would get they would contract the virus, so better not to go there. So this, of course, intensified. Again, there was also a disruption in services and informal responses. So what you mean here is, with many public and private facilities converted to COVID-only facilities, and this happened in most countries, non-COVID services, most of them, routine checkups and other things, even cancer service, so HIV, were postponed or canceled. And this disproportionately affected informal workers who relied on bringing a little bit of money and getting the care, and they didn't have insurance. So again, migrant and urban poor households struggle to secure beds, oxygen, and masks. SOS calls on social media help them, and we'll hear about that here. She didn't basically say how what was their alternative. Daniela, yes, said it, okay, and we'll speak about that later. So a little bit, there were some informal collectives, volunteer networks, multiple aid groups that stepped in to arrange teleconsultations sometimes and oxygen citizens for poor families. But this was especially in big cities like Delhi and Bengaluru, and not in other places. And okay, I'll leave this. So what was the overall pattern? The pandemic magnified structural vulnerabilities of the informal workforce: absence of formal contracts, low and volatile earnings, fragmented safety nets, and residents in congested settlements, far from the quality of public health facilities. You didn't have money, you went to live with a relative, more and more people living in the same room. These conditions meant that the same worker who kept city running pre-COVID were least able to absorb shocks or claim care during the crisis, underscoring the need to integrate informal workers and informal providers into labor, social protection, and health policy in non-crisis. That is like good wishing. It didn't happen. Okay, so she gives 3 examples. I don't know which we'll read. I don't think we have to read all of them. What do we check? Car driver, marble cutter, or one that I don't know. What do we choose? Anyone has an idea? Anyone has a preference?
The car driver.
What? Car driver? Car driver. Let's read it. So Hardeep, a truck driver in his 40s, is the sole earning member of his family. He has 2 daughters, an 18-year-old with intellectual disability, and a 12-year-old, and bears full responsibility for their care and education. Prior to the COVID-19 pandemic, he worked in the tourism section, an informal occupation that provided him with relatively stable and higher earnings. However, during the pandemic, like many drivers, he faced severe economic hardship as work opportunities completely dried up. For nearly 3 years, Hardeep struggled to find employment. With education only up to the 12th standard, that means high school, and skills limited to driving, his job prospects were extremely constrained. During this period, he relied on his social networks to secure occasional work, such as short-distance trips or airport drop-offs. However, these irregular jobs were insufficient to sustain his family financially. Eventually, due to mounting financial pressure, he was forced to sell his car, an asset that was crucial for his livelihood. In 1923, he finally secured employment as a driver with a private company, where he continues to work. While this job offers the relief of a fixed monthly income, his earnings are significantly lower than what he made earlier in the tourism sector. He also expressed concern that following the change in the state government in Delhi between 2024 and 2025, there is a growing uncertainty regarding the continuation of welfare and affirmative measures introduced by the previous government. Although his family currently benefits from certain provisions, such as free railway ticket for his elder daughter and her mother, and educational reservations under the economic weaker sections category. These measures, according to him, are insufficient to meet the household expenses. He often reflects nostalgically on the pre-pandemic period when frequent travel and tourism-related work allowed him greater financial stability. So basically, we have a story of what happened and how he survived with his friends that help him get some job, and how again he has some sort of an employment. I'm not sure what she has, what have here, but in some place, I think this one we can read because it's short and it's different. So this was a skilled construction worker specializing in marble and tile work. Prior to the COVID lockdown, he was engaged in renovation work in Delhi. However, when the national lockdown was abruptly announced, construction activities came to a halt. Even after restrictions were lifted, renovation work remained stalled for 6 to 8 months, as many construction workers had returned to their native villages and were reluctant to come back due to uncertainty of fear of infection. Pawan was living in Delhi with his brother at the time, while his family remained in their village. Like many migrant workers, he returned to the village during the pandemic, believing that rural areas were safer than urban centers, where COVID-19 cases were perceived to be higher. In the village, survival was comparatively easier, as families could rely on agricultural land, livestock, and other local resources, significantly reducing the need for cash income. In contrast, urban survival required regular expenditure for food, rent, electricity, mobile data, and other essentials. Pawan returned to Delhi only 2 years after the pandemic to resume work. When asked why he did not return earlier, he explained that he lacked both the financial means and transportation to travel back. Moreover, he was uncertain about availability of work in the city and feared that returning without guaranteed employment would further worsen his condition. Okay, what we have in common here is that people that didn't have a fixed job or were easily left, and they survived whatever way they could, and many went back to the villages. And villages in India can be 1,000 kilometers or 2,000 kilometers away. So while they survive in the village, some come back and some don't. So I think these are the more or less. I don't think we need to read the next one, but it's maybe the next one is someone that did not get their treatment because of breast treatment because the hospitals were closed. And so this is a completely different case. So her mother that worked in radiology recounted the case of a general duty assistant at a clinic, a woman with a big, large lump on her breast who was unable to access timely health care. Although she was later diagnosed with breast cancer, her treatment was repeatedly delayed. Government hospitals, which were the only economically accessible option for her, remained shut or severely restricted, while private radiology clinics required a negative COVID test report before offering services, and money, of course. This was not an isolated case. Patients requiring regular dialysis or chemotherapy also experienced prolonged delays in care. In this context of scarcity and uncertainty, informal practice emerged as coping mechanisms, bribing hospital staff to secure timely appointments became common, if unspoken, strategy for navigating an overwhelmed healthcare system. And this is like a story. But people, HIV in the first few months completely surged because the treatment was not provided. I mean, organizations like UNAID that used to provide the treatment, there were no flights. Everything was closed. So many people, all this was worldwide, but mostly more still in developing countries that were on HIV. They did not have blown up AIDS, began getting symptoms of AIDS again. So again, she's showing here how the conditions influence these workers, the unskilled workers or the mobile workers or whatever. That's more or less what she wanted to say in her. I'm really sorry she's not here because I heard her, but I can't answer these questions. It's not my area. So I would like to discuss a little bit in two parts. The first part like both papers that focused on COVID, okay? And Daniela, of course, focused on the color of COVID and the pandemic in Brazil. And you use the important term syndemic, which I don't use usually, but it is. It explains actually why you consider COVID and HIV before this as composed of different intertwined biological, social, political. You said it, yeah? And not only a disease, because when we're teaching, when I'm teaching my medical students about illness and disease, like disease is the objective thing, and illness is our own perception, how we feel and how we interpret it. So basically, the the concept of COVID as a disease goes away when you say, okay, it's endemic. It goes together with all these other things. And the interesting thing about Brazil, you explained everything. I'm not going to go back on the socioeconomical, ethno-racial, and all the inequalities. And of course, just like in India, the weakness of the public health system, there was a case that the president at the time like denied the existence of COVID and all its cronies. And he even I mean, it was written in your paper. Here you didn't have too much time to get into it, but this is like a political thing. And then these fighting with I remember this thing of fighting with governments of the governors of the main cities that wanted to have the vaccines, like Sao Paulo and all that. And so this is really, we see how different things interact. Then your very interesting thing is like the skin color's role in all this inequality and how this exists and the race and how, you said something that I actually didn't think about it, but it goes because you're saying that this racism and it sometimes it would normalize the racism and even genocide of blacks and pardos. And that is really a big thing. So again, that when they all these stories related to them and that they caused this and they began this and you said that in your stories, like it is very unique and I imagine it exists in other places, but it's not said in other places. It's not, it doesn't come out in this way. And also the whole group of pardos had had to take care of themselves and their families and had more exposure than others and it aggravated all these things in the favelas and just as we saw in the high risk of death and all this we saw also in like in the India. She says that not blacks, she's speaking of the workers and you're speaking of the paros, but many of them are also uh, workers that have informal jobs, so there's some sort of a thing. Now, another interesting thing on your paper and in the other one also is that because of the rise of unemployment, there is this forced cohabitation of family members, and this leads to increased domestic violence, femicide, and this especially affected Black women, femicide. More Black women were actually killed, femicided, which is not the usual killed. It's killed because you're a woman, and usually very often by someone in your own family, or by a jealous husband or a boyfriend or someone you left or something else. So these issues, of course, were not addressed by the government, and here again, 71% who lost a job were Black pardos. And that is similar to what Lovina wrote in her paper, because she also examines the inequalities in Indian society, and she doesn't focus on race nor on caste. If she was here, I would ask her, what about the different caste? Because she doesn't focus, and that happens in India. But she focuses on the unemployed and of course, and on what happens in urban India. And again, a very big amount of 176 million slum dwellers, 93% of informal workforce without security, underfunded public health things and other things. So she does not use the name systemic, but it's evident in her focus. Yeah, she speak about all the differential factors that Daniela spoke about when she defined for us endemic, and of course points mentioned is differential impacts of lockdowns and disruption of healthcare, and we saw about that. Now, there's another very important issue that Daniela brings up, and actually Lovina doesn't go. She more or less mentions it, but she doesn't go into it, is the alternatives. You know, the alternatives to the government who doesn't actually give the services, the alternatives in the face of the syndemic. And this was based, you again come back to race, like in addition to increase of religious intolerance, especially against Afro-Brazilian religions, black population, and the accusation of black population of improper behavior and of sparing the virus and all that. So these groups come to work, and some associations of these groups, especially of the Afro-American, Afro-Brazilian religions, begin to organize themselves to face the syndemic. In some places, the syndemic in some countries also, a couple of African countries, they also denied it for a while. So here it says we have it, we have to do something the government is not doing, we'll do it instead of them. So the communities of Afro-Brazilian religions is mainly composed of blacks and pardos, and they're located in urban, in the urban, but in the outskirts, Daniela? They're not in the middle, they're in the outskirts?
So there are many black and pardos, yes, in the outskirts, not in favelas, because they were expelled from favelas.
Okay, so they did campaigns of information, preventive measures, and also they also did food distribution where it was necessary. And also they had their services, their traditional services online. So this is in my question would have been if she had been here, Lovina, I would have asked her if vulnerable communities in India also organize alternative community channels. We don't know from what she wrote. Now, so again, listen, Javier, you'll see in the end, I tried to connect. I mean, I yesterday and today, for hours, I thought about this, and I connect and not connect. You'll see what I thought. First of all, my son is a professor in social psychology. So I told him, I had never considered this. He said, oh, in social psychology, we consider it always like a pandemic because they speak about it most. So that was very interesting for me. And I also, your use of online spaces was also very interesting. Actually, one of my young colleagues in the commission, she is working on mental health also, and also using apps and also interviewing people. So maybe I'll make the connection between you guys because it's it's very, very interesting to hear about that. Many people that I know are not doing this. So I've heard about silent pandemics, and I've heard, for example, femicide, even in the WHO, they defined it as a silent pandemic. But I didn't hear this, and this is really, really interesting. And the way of actually exploring, going out of the biomedical or even the biosocial research and going into the reality of the people that live and how they live and how it's part of their life. And the main thing is like going into this thing that the antidepressants simultaneously can produce harm, good care and harm. They can save us and they can bring us a lot of other issues like, I don't know, side effects and other things. And my question is, I was looking, when I read your paper and also here, the people in the groups that you had, apart from someone from India, the quotes you brought, they were mostly from the global north. Is those the most people that use the groups? Or is just,
So in this case, because I'm doing it in mostly English-speaking countries, I mean English-speaking groups. There was one Spanish-speaking group I was part of as well, but because they are mostly English-speaking countries, they're mostly global north. Yes.
It's also very, very interesting. I mean, my comment that's not written in my notes is actually to see because if in Africa, for example, mental issues were often treated by traditional healers with their own methods. I even knew one traditional healer here in Israel. He was Ethiopian and he was fantastic. I mean, the guy had good methods. He knew how to speak to people without having a PhD in whatever. So that was really a question because there is probably a different issue, but it's very interesting. So so the way is actually it's also a little bit similar to the notion of syndemic. if you think about it, we use a little bit of imagination, you're trying to see, how people live the thing and how they feel and how they live in that situation and get out of the medical model of percentages and benefits for antidepressants and listen to the narratives and like experience, as you wrote in one place, happy pills or zombie drugs. Like the same thing can be a happy pill and can also make you a zombie, So this was really, really interesting. And in a way, all these things affect people's decision. And sometimes it's similar to the perceptions of ARVs for HIV or COVID vaccines. If you go into COVID vaccines, people, even before they use them, listen to stories from here, from there, and this helps them decide. Of course, it's different than depression because they don't have a depression, but something in all these things. The other interesting thing is the word for pharmacon. Okay, whoever doesn't know it, and it also goes with the thing of ambivalence. Something can be beneficial, harmful, and it can be also beneficial and also or beneficial today and harmful tomorrow. So this is and also, what you said before, challenging who we are according to all that. So this was really, really interesting, and your way of saying, okay, how to decide, it reminded me a little bit about people when deciding to get a COVID vaccine or not. Some of the things, here with Guadalupe and a few other people, we did a small research about COVID vaccines a few years ago. So this sometimes, the other very interesting thing is the antidepressant journeys. Yeah. And trial and error and with the health providers and without the health providers. So this was really, really interesting. I can say also, I mean, you put yourself in there, okay? In your own experience. And I can say my experience is not with the kinds of medications. This was something else, okay? This was a kind of post-herpetic neuralgia, pain in a certain place. And you also try one thing, try another thing. So those journeys, it happens to many people that have something that is chronic and it's going on. So I just want to conclude. I think that, first of all, the papers were fantastic. I think that some of the terms used in the papers, like pharmaco or syndemic, can be applied to different forms of healthcare, health measures, and planned treatment. And actually, this ethnographic studies based on life experience, cultural beliefs, and social norms, if they go with participation of the community members in trying to plan the treatments or plan everything and not be outside, to be involved, this can really get to better communication and more successful interventions in times of syndemics. And my experience of that was with HIV. When we worked in communities, inside the communities, like rapid assessment, that means that we trained 15 people. They all went to get into the community for 2 weeks and interviewed and did focus groups. But then they got back because it was something planned by UNAIDS and by the government. Then they went back and said, "Oh, we found this. What can we do?" So they sat with the women and pregnant women. They sat with commercial sex workers. They sat with all the groups. And so basically, if people are hard and participate, it can get us to much more successful interventions. And that's more or less my quite long comments. So please, like, if anyone has questions, one from the other, or in Guadalupe.
Okay. Thank you very much, Anita, for your reflections. And thank you as well for the presentation by Daniela and Javier.
Oh, by Ken, okay.
And I believe all the presentation point to a common denominator, the role of the social determinants of health. They highlighting how each of us is shaped by circumstances rooted in a structural condition that, for example, perpetuate resistance, determinant access or lack of access to a specific medication, exacerbate particular health condition, and shape the way in which we access health service, vaccines, and health information. They also speak to how we in turn make decisions about our own health and about the information we receive from healthcare providers. It seemed to me that the role of public policies runs throughout this discussion. I think the specific role of the public policies mark the ways of these specific programs or other activities in the countries. And Anita or maybe Daniela or Javier, any like to other comments or as begin to wrap up the session? Daniela?
Yes, I would like to make it to be more precise about what I answered before to Anita, because indeed in Afro-Brazilian religions now there is a bigger number of white people, but they were so strong in pointing out racial issues of all the kinds that I explained, and even others, that they were very active to face the pandemics in various ways. And they pointed out race in a very strong way from the first beginning. And I would like also to make a small comment to what Guadalupe said. Indeed, I don't use much the term social determinants of health because in my research it comes more an intertwining of racism and various socioeconomical factors with and others with illness. For instance, the fact that not only racism exposed much more certain part of the population, but also all what happened increased the racism. So they are very complex relationships that sometimes is difficult. Surely we have social determinants of health, but it is really very complex.
Yeah.
Also religious, I had not the time to speak about religion. That is quite important also because most Black people, Black poor people and from favelas are of neo-Pentecostal churches who had a very strong denialist position, and they were collaborating and very near to President Bolsonaro, and they succeeded to have temples open and religious service as an essential activity, so they could continue their activities and religious services.
Why do you think the Pentecostals were working with Bolsonaro? I mean, whatever you think, because I know Pentas in Africa and they were not working with government. So I don't know, is there any reason?
So first of all, he declared himself to be Christian. He made the baptism. He was very near to very important pastors, and new Pentecostal churches are very inside power in Brazil, not only under Bolsonaro, also in other governments, and also in alliance with traffickers of favela. And that's why there is almost no Afro-Brazilian religion in the favelas.
Thank you.
I have a comment. Thank you, Daniela, for your comment. In the case of Mexico, for example, we have categories based in the self-identification as indigenous, non-indigenous, and Afro-Mexican population. The inclusion of Afro-Mexican is a category relative recent. For centuries, Afro-Mexican population were denied recognition. And well, your presentation, well, it's so important because we in the case of Mexico, we deny totally other categories and basis in this classification of the census, of course.
In concerning race and racism, Brazil is really very complex, also because of the idea of the racial democracy that was presenting miscegenation as the value for Brazilian identity and culture. So they denied differences, and these differences, and especially racism, and the inequalities that were present and continuing, and these delayed very much the formation and the activity of the Black movement, and also many other actions.
Javier, would you like to make another comment?
Yeah, sure. I think in my case, right, you were discussing about these structural determinants of health. I think in my research, I didn't quite get much into this in my own presentation. There's a lot. Mostly, I didn't get much into it because there's so much research about this topic on antidepressants, right? Well, there's never enough, but there's already a lot. Certainly, in my case, there's a lot that has to do with economic inequalities regarding access to health, regarding access to pharmaceuticals in this case. And there were a lot of, there were instances of people who told me they couldn't pay for the pharmaceuticals during that time, so they had to quit. They basically had to quit. These were instances of people who were in the US, where, as you might be aware, it is quite difficult, so, without employment, without insurance, and so on, access to basic health services. So in this case specifically, it was a lot of economic inequalities. I would find for sure, if I had the chance to speak with people from many other countries, I would for sure find other experiences that also relate to matters such as ethnicity or kind of what Daniela was referring to when we were talking about COVID-19. Certainly the access to pharmaceuticals for mental health, it is very, very much not the same across the globe. These are just, a given almost in global north, but not so much in the global south. But just to point this, kind of also trying to point this because there are people who have done much more in-depth research on this and better than me. And here, I only have some, the first person experiences of those who go and check those barriers. But there are, of course, these very, big studies with lots of data from all over the world that really reflect on these inequalities and how they much affect, first of all, from access to health, but also being diagnosed in the first place, or suffering from mental health in the first place, and how it is very much determined by these health determinants. Yeah, thank you.
Thank you, Javier. And well, Javier, I have a question. In your experience, have you observed cases in which people do not have access to the best possible treatment, particularly in terms of newer generation of medication, even through treatment it's available, perhaps a cheaper option, but not the most effective one. For example, in the concept where your country conducting your fieldwork, have you documented situation like this is asked because in Mexico, within the public health sector, some older and less expensive medication are still commonly used, even when most recent alternative exist.
So in this case, I would say, well, from the people I talked to, nobody told me this was the case. It was rather on antidepressants or without them. From what I know, at least in antidepressants, there are differences in price. They are not very, very big. They are not huge differences in price. And the thing is, the kind of antidepressants that I'm doing my research about, these very, very common ones, are also some of the cheapest ones. So it's not like there's a cheaper, older version. These have been out since the 80s, right? These antidepressants that are extremely common are the same kind that have been going out since the 80s, right? If you have heard about Prozac has this buzzword. So they have been going out since the 80s, the 90s, have taken all over the world, and they're still here, right? And these tend to be the first antidepressant people get prescribed, this kind. And the other kinds are usually a second option, right? There are these other new variants that tend to be prescribed only after these SSRIs, this kind that I'm researching, are not proven to not work for this person. That's when they kind of, the person who is prescribing, the GP or the psychiatrist or whatever, leans into these other kinds, right, that have come out since early 2000s and so on. Or they might start getting into even less common variants that have been out or were first out in the 60s, which they're very rare. But in some instances, people are prescribed them just as a last resort when nothing else is working, right? But from my experience, it doesn't tend to be the case. Rather, what the cost becomes an issue is when trying to get an appointment in the first place to be prescribed them, right? Rather than the cost of the pharmaceutical. At least, from the people I've talked to, which might not be the case, everywhere all over the world, might not be the norm, but at least from my research, yeah.
That's a problem when there's not free access to everyone, which is the ideal situation. In this case, I have to say that I'm very lucky, but it's except for example, again, we're on to undocumented workers or workers that are asylum seekers. They're the only ones that don't have all this thing, but their children and pregnant women do. So it's but I never realized, it's so important because you go places and of course you don't get maybe always exact thing and you have to wait for specialists also. But in the end of the day, when you have a salary, it's deducted from your salary every month, a certain amount, and that's the way this thing gets paid. So, But the more I think of it, I think that this is like one of the most important social things that should exist because I don't know if you heard Gabriel. I'm asking you this question because I know it in one or two countries, not from where you come. And the use of traditional healers for depression and that. How does that work when people can't get to a doctor? Do you know?
Yeah, I can say in case of country where I come from, Zimbabwe, and also I've seen it also in South Africa that they use traditional healers more than relying on 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 biomedicine or medical doctors. So if someone is mentally ill, mostly in Zimbabwe they go to a traditional healer. So it's quite I think almost 90% of people, when it comes to mental issues, they go to traditional healers more than the
More than-
GPs.
when it's
Yeah.
maybe better than taking all the medication, who knows, for some things. I personally believe this in some cases, but yeah, that's a big story. It was very, very interesting to hear what you're doing and what the experiences of people are.
Yeah, I mean, definitely. I think if we can point at an issue, I think the issue is taking for granted that biomedical or West or global North biomedical model is the only way to go, right? It doesn't need to be, and there are definitely alternatives. Of course, we would need to explore further on those
Yeah, but the
alternatives. How they
alternatives
work.
sometimes give you community support and other things, and then sometimes the people
Definitely,
need the support. Yeah.
definitely,
No,
definitely. Yeah, the care doesn't need to go through the antidepressants. Definitely.
yeah, for everyone. That's very interesting.
One last thing. Also, in Afro-Brazilian religions, they treat mental health, and indeed, some mental disorders are often related to some spiritual issues. But what I observed more and was so strong during the pandemic is how they care of all aspects of the person's life and devote so much time to talk, to understand. They also, especially the candomblé practitioners, defined the priestess as a psychologist or a psychologist of the poor.
Yeah. That is, it reminds me of stories, but it's not exactly related. I won't tell it, but yeah, this psychologist of a certain community, or I don't know what. Do we have 3 minutes, Guadalupe? I want to share something with you because it's something that happened 25 years ago, but it was very interesting, okay? We have a few more minutes, so we have to close.
No,
Can
please,
I share?
Yes, please.
Okay, so I worked many years with the Ethiopian community that immigrated to Israel in the 80s and 90s, and then little by little. And I was friends with I actually studied traditional medicine, so I was very interested. I'd been to traditional healers in Argentina, where I lived most of my life, and then in other places also. So one of them said, "Well, we're going to introduce you to our father when he comes." The father was a very important traditional healer in Ethiopia, and when all the healers were banned from the military, I don't know, government they had there, they only left 6 that continued to work on with this man. They came to ask him things: what will happen? What can we do? The governor of the anyhow. Many of his children were in Israel. He came here once he was about 80, and he went to live in an immigration center. So my friends, 2 of his sons that were here before, they wanted to take me to introduce him. When he came, the person that was with him, a person that worked with a ministry that had known him in Ethiopia, they asked what is his profession, and the other guy say psychologist. this Israeli guy. So they wrote psychologists, even though he was an excellent Hebrew. But anyhow, that was not the story. So I go with one of the sons to visit him, and he was in this immigration center that has 3 floors, and different immigrants receive for a period of, I don't know, 6 months or something, a year, apartment while they learn the language and all that. Okay. When we arrived, there was a lot, and the one thing the father said, that now he arrived in Israel, he's not going to work anymore. That's it. He's old. So we arrived there, and there was a line coming out from the absorption center till the corner of Ethiopian immigrants. What was this line? All the people that heard he was here and had some problem that the Israeli medical system didn't understand. So they were waiting for him. So actually, he was forced to work. He never worked like that, but during all the years till he passed away when he was 95, people came to him, and he didn't take money. People left like it wasn't sure about what they wanted. They could bring coffee, they could leave money if they wanted, and like that. And this was, I came once, and a woman came up with a sheep. Now it was a third floor apartment in a city, a mixed city, Jews, Arabs, Ethiopians, whatever you want. It's called Lud. And a woman came up with a sheep. Now, for me, I was there with one of the sons, and like a family member. I did a lot of things with them. But later, I heard the story. This woman had lost many children, and when he came to Israel, she was pregnant, but they told her it's a pregnancy at risk. You should terminate it. So she came to see him, and he said, "No, you just go and rest. You will have a healthy boy." Son used to say that he was like a human X-ray, the father. But anyhow, she had this child and all this, so she made a promise that this is a very religious thing, not only of Jewish, other people. If this happens, I will do something good. So she made the promise she will bring a sheep. In Ethiopia, no, to bring a sheep was a big thing. Anyhow, so they managed, they anyhow bought sheep once in a while there to go fix it, do the meat and parts and all. But that was such an interesting story. So again, healers transport themselves sometimes with their communities, and people use all the Ethiopian immigrants use the Israeli medicine system. But some things, they say there are what they told me Ethiopian diseases. It's not really Ethiopian, it's feelings and things. So again, I again feel, going back to what I asked Gabriel and what you said, there's so many ways, and we just can't be in anything just like again, you said there are also the religious people in the Brazilian, the Afro, they also did treated mental things, and I'm sure they help people. But again, if someone is on a thing that he's going crazy, needs hospitalization, maybe that's an extreme. But for other things, yeah, so it's very interesting. It went out of our thing, but COVID was treated that way also in some countries, Guadalupe, and HIV.
Yeah.
There was a president of the Gambia that cured COVID until people came to him and he cured them. Then they threw him out, but that was the thing that he used to do also. So, did you hear of that one, the Gabriel?
Yeah, I heard about it,
Yeah,
and even the treatment was quite. I mean,
yeah,
it worked for the population. So
yeah, yeah. So
yeah,
again, things. So you have things like this or like that for all the different syndemics that we talked about. Yeah.
Yeah. Thanks for sharing, Anita. And I would also like to take this opportunity to comment that starting next year, we will begin implementing universal access to healthcare in Mexico with
Wow.
the aim of reducing the fragmentation of the health system. Previously, we had different institutions depending on employment affiliation. I would like to think that by 2026, barriers to accessing treatment and medication will be reduced. With this in mind, I would like to ask Javier, Anita, Daniela, Gabriel about access to health service in their respective context and whether there are policies in place for universal access to healthcare? Daniela?
Yes, I will speak of Brazil. That is my field of research. I also lived in Brazil. The public health system is completely free and everybody has access, also foreigners, and they don't ask documents. They often offer you basic drugs for free for your treatment. It has some problems, but surely it is a very good thing to have it in Brazil. For instance, compared to Italy, when you often have to pay a small tax for all the consultations you do.
And how about you, Javier?
Yeah, for me, it's a bit hard to comment because I have my side of research, in a sense, is these online spaces where I have people from all over the world. So, in this case, I had a lot of participants from United States. So, I think everyone is kind of aware, at least to some extent, how difficult it is access to healthcare in the US, and how any efforts for universal healthcare in the US are pushed back very strongly. So that's quite of an issue. Right now, I'm here based in the UK, and I'm originally from Spain, which both have, at least to some extent, these health systems that are open for everyone to enjoy. Now, I think the other issue is, once you have access, right, there are these other difficulties attached to it, meaning, it's not only access to a GP, but it's also that you can get an appointment earlier, sooner than later, right? When you have an emergency and you have to go to the emergency room, so you don't have to wait 6 hours, which is something that I've heard about quite often here in the UK, sometimes in Spain, depending on where you're based at. And when you need a specialist to look at your case, if we're talking about mental health, if you want a psychiatrist, and the appointment is not going to happen until 6 months, and you are dealing with something very serious right now, of course, even if you have, theoretical access, there's quite some ways to improve it. So, so there's that, I think it's complex here. One of the issues with that is that because it's so difficult to access psychiatrists, now everyone is getting prescriptions on antidepressants from the general practitioner, from the GP, and it brings another range of issues in itself. On to what extent do they have the expertise, the knowledge to do that? But yeah.
Yeah.
Okay,
Well, I
Javier.
think the issue of the specialists is everywhere. I found a way to overcome it, but we work online. You get in your medical service, so I found that very late at night or very early in the morning there are cancellations, and you find it. You're 3 months back, and all of a sudden, but that is sitting at it. It's not the way to do it. Yeah, very, very, very. But if you go to an emergency and you'll get the expert also in the emergency, because emergencies are in hospital. But again, no one wants to do that. Yeah. What's the system in South Africa? You told me a little bit about it. Remember, Gabriel is finishing his PhD in South Africa. But again, he's not a South African. So you can give a personal thing, because that's more or less what we're all doing, so we understand.
Yeah, I think first I have to speak about my country.
Yeah.
Because in Zimbabwe, it's quite difficult. Yes, constitutionally, it's there that they offer universal access to healthcare to the population, but practically, it's quite difficult. I think it's also because of socioeconomic issues, because the country has gone through different phases of economic, economic backdrop. So it really affected the funding of the healthcare system, particularly medication and also payments for doctors in public hospitals. So it really affected the access. Yes, the elderly, they access it, but they start to have free access to, let's say, 70 years and above, for free access, and then also children. But for the general working class or able-bodied people, there's no access or universal access to healthcare. So it's quite difficult. And I've seen also in South Africa, South African context, it's almost the same, although South Africa is a bit a step ahead when it comes to the poor population, because they offer access to mostly the poor communities, free access or universal access to healthcare. So South Africa is a bit better than Zimbabwe when it comes to that.
So theoretically, you have free access, but you have to pay. Like if you want
Yes,
to get it, yeah, that's more. That happens in so many countries.
yeah, you have to pay, and it's quite expensive.
Yeah.
Quite expensive, and I've seen also in Zimbabwe that most people are now resorting to alternative medicine when it comes to healthcare, or care, basically, because they find it difficult they can't purchase uh, medicine from the pharmacies, because it's quite expensive, and most companies that used to produce pharmaceuticals in Zimbabwe, they closed during the recession. So they import biomedicine or Western medicine, and it's now quite expensive for the poor and for the general. So most people, they are now resorting to alternative medicine or traditional medicine. Yeah.
No, yeah, go ahead.
In Cameroon, there was a medication, two actually, that were approved by the Ministry of Health for COVID, for prevention or treatment or something. And they both, I saw it because my colleague sent me the picture on both sides. It said approved for the Ministry of, but only for sale in Cameroon, which was it was made of plants of some sort. Yeah, people said it was good, but yeah, we don't know. You know, many of the modern medications, their origin were in plants that were later. That's a whole different issue, yeah. But there's a lot on that.
And Anita, how about the case of Israel about the free access?
That's what I said. It's free access. Whoever works has to, when he goes to work and he fills out, he has to fill out what sick. You have to pick a sick fund. There are many of them. You can pick whatever you want, and you pay. I don't remember what percentage of your salary, and then you have free access to everything, even to operations or whatever. Now I'm going to have a cataract operation next week, so it's a combination because the doctor works with the surgeon works with that, but I'm going to have it in another place, so I pay her a very small extra, you know. So I waited. I mean, it was not urgent. You wait a bit. Some things are urgent. You can't wait. But a cataract operation, you can wait. Yeah, I waited, and I hopefully it will go well. So, but it's free for everyone. And again, there's a very small group that is not. There was a big. I'm going back many years. There's one very good NGO. It's called for HIV. It was the first and the biggest NGO. And at the time, the government was not giving undocumented or people that hadn't finished their requests to stay, or as they didn't get many of the service, they didn't get the HIV. So this organization was getting drugs from all over and giving, but at one point there was a lot of there was pressure, and then they came into this also. So now for the last 10 years, everyone, doesn't matter if you're not documented, yes, documented or whatever, you go by number and you get that. But for the local population, 8,000 Jewish population, 2,000 Arab Muslim population, everyone has the same stuff. That is very good. And it's been again, it's if someone wants to pay and get something sooner, get another, there are private places also, but the system is good. That's other things aren't very good here right now. The whole democracy is in a chaos, but that meantime is and other things. So yeah.
Well, thank you once again to Daniela, Javier, Anita, well, Lovena for their notes, for your presentation, comments, and reflections. I believe the topics addressed today offer powerful insight into multiple areas of work and interest within anthropology and the social science more broadly. Thank you very much for your participation in this seminar. And we will now move on the second part of today's program. So please stay connected. We will begin the cultural activity, which will consist of a poetry reading by 3 invited participants, myself included. We are lovers of poetry, and for today's session, each of us has selected 2 poems. The poems will be read in Spanish, and we will share the English translation on screen so that everyone can follow along. And without further ado, I would like to give the floor first to Gris Hurtado Alcántara. And Gris Hurtado Alcántara, she will reading the poems I'm Not a Poet and Rain in Gaza. And let me to share, please, one moment please. Let me to share, one moment please. Okay, yeah. Okay. Gris Hurtado, the floor is yours. Thank you.
Hi, my name is Grace. Bueno, les voy a leer 2 poemas. El primero se titula No soy poeta. No soy poeta, escribo. No para recibir elogios ni aplausos. Tampoco para que me llamen poeta. Escribo, porque escribir representa todo lo que soy y todo en lo que creo. Y todo lo que no me atrevo a gritar, la pluma y el papel lo gritan por mí. El amor que arde en mi pecho, la rabia que habita mi voz, la tristeza que guarda el silencio. Escribo, porque el día en que se detenga la pasión y la firmeza con que mis manos se funden con las letras hasta hacer el amor con las palabras, ese día dejaré de existir. Ese fue el primer poema y ahora les voy a leer el segundo, que va dedicado al pueblo palestino y se llama Lluvia en Gaza. Y un momentito. Desde esta parte del cielo, todo parece tranquilo. Sin embargo, del otro lado nuevamente se vive el holocausto. Monstruosidades se han cometido en el nombre de Dios, y con o sin su nombre se siguen cometiendo. Desde aquí, sin poder hacer nada, no tolero el ruido de los fuegos artificiales, porque allá, estruendosas caen las bombas una tras otra, arrebatando vidas, arrebatando sueños. ¿Quiénes son aquellos infames que las lanzan, sin piedad, sin alma? ¿No somos pues hechos de la misma carne, hijos de una madre, de un padre? ¿Por qué tan prepotentes con sus armas le roban a los niños el aliento, dejándoles sin familia, sin hogar, sin alimento? ¿Qué se han creído ustedes? ¿Qué les ha dado el derecho a proclamar tanto sufrimiento? Asesinos, homicidas de la vida, genocidas del amor. Detengan, paren el holocausto, que se detenga el exterminio, quemen las armas, destruyan las balas, que ni un alfiler sea usado para lastimar a mis hermanas, que se detenga la lluvia de fuego, que mis hermanos no sean asesinados. Gracias.
Muchas gracias, Gris. Thank you very much, Gris Hurtado, for sharing your work. We will now give the floor to Susana Ferrat Machado, who will be reading the poems Freedom and Society. Let me to share again. Okay, welcome, Susana. The floor is yours.
Hi, good afternoon. My name is Susana, and the first poem is Freedom, libertad en español. ¿Qué es la libertad? ¿Acaso sé su significado? ¿Estaré disfrutando del todo? ¿Por qué me niegan conocer tan maravilloso arte? ¿Por qué, amarga sociedad, me cargas con tanto equipaje? Ese fue el primer poema, the first poem, and the second is titled Society. And I wrote this in the pandemic, the COVID. It is, ay, sociedad, ¿qué han hecho contigo? Ya la ciudad no respira el aire que tenía hace siglos. Se han perdido los más anhelados valores y el puro amor se quedó en el olvido. Nos hemos vuelto caníbales, robando y lo peor, matando, para lograr sobrevivir a una sociedad convulsa que se ha convertido en marea de un mar bien enfurecido y que hoy son nuestras calles, todas repletas de sangre, aclamando por todo lo que has sufrido. Hoy lloras desesperada, sociedad, porque se ha perdido la humildad y te has quedado sin anhelo y en un profundo vacío.
Bravo.
Thank you. This is the end. And this is my book. Buy it in Amazon.
Thank you very much, Susana, for sharing your poems. And
Thank you. You're welcome.
we will now give the floor to Fanny Alejandra Gomez Garcia, who will be reading Everyday Resistance and You Exist Better Here. Let me to share again. Okay, go ahead. Fanny, the floor is yours.
Thank you. Hi, everyone. I start. Sí, tenía 10 años. Salí a comprar al mercado. Me tomaron de la mano. Me llevaron a una calle que daba al río. Recuerdo la sensación de asombro. Me impresionó saber que a cuadras de casita pasaba un río. Mamá siempre decía, Derechito al mandado, derechito a la casa, y no hables con nadie. El río enmudeció, los carros dejaron de pitar, la gente dejó de hablar. ¿Cuál era la pregunta? No, a los 10 no hice mucho. Jugaba con mis primas, era llorona. A veces me hacía pipí al dormir. Mamá me regañaba. No quería comer. Mamá me regañaba. Dejé de ir al mercado. Mamá me pegó un par de veces. Por floja, decía. Thank you. And the next poem. Existes mejor aquí. Por la mañana, mientras lavaba, veía el cielo. Pensaba en la tristeza que me causa ver las nubes y no saber volar. Sin darme cuenta, él se acercó, pasó detrás de mí, con su caminar sereno y elegante. Amable y cálido, me tomó de los hombros, me giró despacio, me vio a los ojos, tocó mis mejillas y dijo: ¿Qué tienes, princesita? ¿En qué piensas, mujer? ¿Qué tiene mi ángel del consuelo? Mi muñequita, tienes las manos frías, ya te cansaste, ¿verdad? Ay, Esperanza, eres tan noble, eres tan sacrificada, eres tanto amor. Por eso te amo, mi Esperanza, por simple. No eres mucho, ni eres poco, eres ideal. Ahora pienso que él pierde el tiempo conmigo y confirmo que existo mejor donde él me quiere. Yo no sé volar. Bueno, no aprendí. No soy pájaro. Alas no tengo y ganas tampoco. Thank you.
Thank you, Fanny, for sharing. And I will also read two poems. The first is titled The Light That Blinds, and the second poem is Killing Dragons. Let me to share. La luz que ciega. ¿Cómo podemos definir la luz de alguien? O para ser más claros, que alguien es luminoso. Empiezan a cegar tus palabras, empieza a cegar tu trabajo, ciega tu sonrisa, ciega tu forma de vestir, ciega tu físico, ciega el color de tu piel, ciega tu juventud, ciega tu amabilidad, ciega tu bondad y sobre todo tu inocencia de no ver la maldad de otros. Y eso es lo que más ciega. Solo eres luz. Eres luz. Hay gente que lucha en apagarla, pero sabes que no podrán. Hay mucha energía. La luz es infinita. Matar dragones. Si todo se va a descarrilar, hay que agregarle todos y el mayor número de sinsentidos posibles. El guión no importa, da lo mismo. Todo retórica. Yo actúo normal. Los demás siguen simulando. Siguen y siguen y siguen y sigue y seguirán creando situaciones imaginarias, inexistentes. ¿Es posible? Construyendo la verdad a partir de la ficción, la posverdad. Traslapan la realidad, jamás existió ni existirá, cada día es una prueba. Me pareciera que siguieran un camino para convertirse en una monstruosidad. Es un monstruo. Matar dragones en una situación como esta. Entre más burdo, más creíble. La pandilla de las mentiras. Necesitamos matar dragones. Espero nunca convertirme en un monstruo más. A veces me pregunto qué sentirán y si se habrán dado cuenta de lo que les pasó en ese tránsito, en ese rito de paso repleto de falsedad, ya que pareciera que están convencidos de esa realidad que simulan habitar. Matar dragonas con la verdad. No hay más. And, well, once again, thank you. Thank you to Grace, Susanna, and Fanny for sharing your poems. And thank you to all of you for joining us today in this session, which is the penultimate session of the international seminar. I would like to invite you to join us tomorrow at 10 a.m. Mexico time for the final session of the international seminar, which will be held in Spanish. I will take this opportunity to say goodbye and to thank you each and everyone for your participation, and have a wonderful morning, afternoon, or evening, wherever you may be. And warm regards to all, and thank you very much.
You.
Thank you.
Thank you. Bye bye.
Thank you, Lupita. Bye.
Bye.
See you.
Gilberto, ¿puedes
Bye.
terminar?
Gracias.
Gracias, Susana, Gris, Gilberto. Gilberto, ¿ya terminaste la grabación?